Assalamu alaikum. My name is Tahsin Mubin. Today my topic is anti-epileptic drugs and I am going to discuss effects of anti-epileptic drugs on spontaneous recurrent seizures, SRS for short, in a novel model of extended hippocampal kindling in mice. Starting with the introduction, epilepsy. As we all know, it is a common neurological disorder characterized by naturally occurring spontaneous recurrent seizures and comorbidities. We have different types of drugs to treat this disorder called anti-epileptic drugs, AEDs for short. We have different examples of AEDs such as sodium valproate, carbamazepine, lamotrigine, levitar acetamine, and topiramate. Now we are going to discuss the process called kindling. It is a process by which a seizure or other brain event is both initiated and its recurrence made more likely. Why we are studying kindling? Because it has long been used to model epileptogenic mechanism and to assess anti-epileptic drugs. In particular, extended kindling can induce spontaneous recurrent seizures without gross brain lesions as seen clinically. To date, the development of spontaneous recurrent seizures following extended kindling and the effect of the anti-epileptic drugs on these seizures are not well understood. In the present study, we aim to develop a mouse model of extended hippocampal kindling for the first time. Kindling related to epilepsy. Classic kindling over a few weeks does not generally induce spontaneous seizures. Extended kindling is able to induce SRS in several animals. Basically, extended kindling is a condition in which amnesia is also applied to the patient. Specifically, extended kindling of the amygdala, hippocampus, perforant path, or olfactory bulb induces SRS in monkeys, rats, etc. Several studies have been examined. Classic kindling seizures in mice. No extended kindling mouse model has been established yet. In this sense, we aim to develop such a model to facilitate future ectogenesis research and the possible effects that AEDs might have on SRS. The drug we are going to test is Levitar Acetamine. It is an anti-epileptic drug marketed since 2000. Its novel mechanism of action is modulation of synaptic neurotransmitter released through binding to the synaptic vesicle protein SV2A in the brain. Brain cells normally talk to each other using electrical signals and chemicals. Seizures can happen when the brain cells are not working properly or working faster than usual. Levetiracetam slows down these electrical signals to stop seizures. The EEG monitoring stands for electroencephalography monitoring through electrode implantation. The method is 6 to 8 month old male C57 black mice were obtained from laboratory and housed in a local vivarium. Vivarium is basically a cage with artificially environment. Several months before the experimentation, we used to take the mice in this vivarium. This vivarium was maintained between 22 to 23 degrees centigrade with a 12 of light on-off cycle. Mice were placed in standard cages with food and water. We use male mice to avoid variable female sex hormones on kindling process. All these experimentations are conducted under the guidelines of Canadian Council on Animal Care. For electrode implantation, mice were anesthetized with isoflurane and placed on the stereotaxic frame. After skin incision and exposure of the skull, small holes were drilled through the skull and electrodes were inserted to the brain by micro manipulators. Electrodes were secured on the skull using a glue-based anchoring screw-free method. To induce hippocampal kindling, a train of stimuli at 60 Hz of 2 seconds was used for kindling stimulation. Constant current pulses with monophasic square waveforms plus duration of 0.5 millisecond and current intensities of 10 to 150 microampere were generated by a grass stimulator and delivered through a photoelectric isolation unit. Levitar acetam was obtained as a powder form sigma aldrich, dissolved in distilled water as a stock solution and stored in freezer at minus 20 degrees centigrade before usage. This stock solution is appropriately diluted with saline and applied via intraperitoneal injections. The dose is 0.5 ml per injection. Dose of levetiracetam we have tested is 100 and 400 mg per kg. After the administration, the EEG signals were collected using two-channel or one-channel microelectrode AC amplifiers with extended head stages. Baseline monitoring was conducted 1 to 2 weeks. Post-electrode implantation EEG monitoring of 24 to 72 hours per session was conducted after the 80, 100 and 120 or 140th stimulation to assess the SRS commencement. If greater or equal to 2 SRS events were observed in 24 hours, no further stimulation was applied and additional EEG monitoring for up to 72 hours was performed to assess initial SRS incidences. EEG monitoring of 24 to 72 hours was repeated 8 to 11 weeks later to assess SRS stability. The effects of AED was examined afterwards. For each mouse in the control group, continuous video EEG monitoring of 48 hours were performed after 60 days of twice daily handing manipulation. Now we have the graphical representation in which we have the electrode implantation in the first 2 weeks, the baseline monitoring we have on the second week, and we have extended kindling or handling manipulation up to 11 weeks, and then we have the SRS monitoring 8 to 10 weeks of the SRS monitoring and AED test, and 2 to 3 weeks afterward the brain histology is obtained. We have the baseline graphical representation, and we also have the extended kindling graphical representation, the irregular activities after the administration of drug. So now we have concluded some sort of result after this experiment. First I'm going to show you the graphical representation of this method. We have 2 doses of Levitar Acetamine, one in 100 mg per kg and second is 400 mg per kg. We are comparing the effects of anti-epileptic drug with the saline solution. In this bar graph we have the section A called SRS incidences events per 10 to 12 hours. As compared to the saline solution, we have Levitar Acetamine 100 mg per kg, in which reduced SRS incidences have seen, and no seizures on Levitar Acetamine with 400 mg per kg we can see on the A graph. Now we have the B graph in which we have ictal discharge durations in seconds. As compared to the saline solution, we again have the reduced ictal discharge durations as compared to the saline for Levitar Acetamine 100 mg per kg, and in the case of Levitar Acetamine 400 mg per kg we do not have any ictal discharge durations. Now moving towards C graph, we have motor seizure stages, in which we have again decrease motor seizure stages on the Levitar Acetamine 100 mg per kg as compared to the saline solution, and in the case of Levitar Acetamine 400 mg per kg we do not have any motor seizure stages. Now the last graph showing the enterical spikes events per 10 minutes, in which saline solution again compared with the Levitar Acetamine having a greater enterical spikes, and the Levitar Acetamine with 400 mg per kg as compared to the saline again have reduced enterical spikes events per 10 minutes. So here we have different patterns of anti-epileptic drugs effect which are given in the result form, and now I'm going to read the result for you. Levitar Acetamine at 400 mg per kg abolished SRS in 6 out of 6 mice tested. As we have seen earlier, SRS incidences were 3.8 plus minus 0.6 events per 12 hour following saline injection. These are hippocampal discharges, non-motor seizure detected following Levitar Acetamine injections, whereas the incidences of hippocampal enterical spikes were not significantly different between post-saline and post-Levitar Acetamine measures. And the values are given. Levitar Acetamine at 100 mg per kg was variable in suppressing SRS. N is equals to 5 mice. SRS incidences were decreased in 4 out of 5 mice tested, but the overall SRS incidences were not significantly different between post-saline and post-Levitar Acetamine measures. There were no significant differences between post-saline and post-Levitar Acetamine measures about corresponding hippocampal discharge durations, motor seizure stages, and the hippocampal enterical spikes. I hope you guys can understand the total procedure, and that's all from my side. Thank you very much.